Hey everybody, it's Rob Cascado, Physician Associate in the Dermcast Live studio, and I'm here today with a person that we love to have us visit and drop by. It's Dr. Matt Zirwas. Welcome, Dr. Zirwas.
I am thrilled to be here.
Yeah.
By the way, this SDPA meeting, off the charts.
It's next level, right?
Off the charts.
Okay, yeah, I'll run that up the ladder and make sure that people, I don't have anything to do with planning it, but they did a great job.
Off the
So,
charts.
of course, no meeting would be complete without your presence, and I just watched you give a lecture on your updates for atopic dermatitis, and this is a space that's changing like crazy. We got topicals, we got systemics, we got new interleukin that we're blocking, all kinds of things. So we're going to get into this a little bit. There were a lot of questions that didn't get answered, so we're going to touch on that too. But let's start with this. You mentioned in your lecture some of the published data and some published articles revolving around IL-4, IL-13 blockage, and JAK inhibition. So let's get into this. The first thing, tell me about your interpretation of data in terms of JAKi, JAK inhibitors, having a cardioprotective effect, because this is not what we're used to thinking, right?
Yeah.
Not at least what we see on label, what the warning labels say. So tell us about your interpretation of data.
So this story first started a couple of years ago. A meta-analysis came out showing that in the placebo-controlled portion across indications for Rinvoq, the Rinvoq-treated patients had a 40% reduction of cardiovascular events. So that was like, oh man. And now in the rheumatology literature, the way that they interpret all of the data is that it is not that if this is the baseline risk, it's not that JAK inhibitors made it go up. It's that JAK inhibitors made it go down and TNF inhibitors just made it go down more. And that is consistent with the label. Right, because the label says an increased rate compared to a TNF. It doesn't say an increased rate, period.
Right, okay, and so this is an important distinction because on the surface, when you read that trial that they made, that the FDA made them do.
Made Xeljanz do.
Right, exactly.
Yes.
It's plain as day that it didn't show at least non-inferiority to...
There were more cardiovascular events in the Xeljanz-treated patients than in the TNF-treated patients, no question.
Right, and so that's the important distinction. You said, we know this, it's well published, the cardioprotective factors of TNF, we've seen that data.
Yes.
And if you're comparing something that might drop it also, but not as much, there you have to say that it did not meet that endpoint of non-inferiority.
Yes.
So this is, I think I have personally never heard the data spun that way, so I'm glad that I heard that today. So that gives us a little bit of reassurance for therapeutics with JAK inhibition.
For sure.
Yeah.
For sure. So I don't tell a patient, hey, this JAK inhibitor is going to reduce your risk of heart attacks.
Right,
but
right.
The way that I very specifically phrase it when I'm talking to patients about the box warning, so I'll pretend like you're a patient.
Yeah.
So, well, this medication, I just want to warn you, you're going to get warnings from the pharmacy that talk about some really scary sounding things. When this medication first came out, we didn't really know if those were risks. We have thousands of years of data on patients being on this drug now, and the data has shown no increased risk at all.
Right.
Now, what are those scary sounding things? Well, they're scary things. Heart attacks, strokes, blood clots, cancer, death.
Yeah.
But the thousands of years of data we have on patients have shown no increased risk.
Okay, so that's reassuring. It's something, maybe you're saying, hey, just make sure you're getting your yearly checkups to the doctor, do all your checkups.
Do your normal stuff.
Right, okay,
yes,
great.
But it does not, whatever your risk is not on the medication, that is still your risk on the medication.
Okay, great. So let's turn our attention now. That's fantastic. That's very useful information in practice. So let's turn our attention to IL-4 inhibition, IL-4/13.
Yep.
You mentioned, well, we know that there is on the label a warning for CTCL, okay? A population that we know that there is a risk of this. So tell us your interpretation of that data in terms of something like dupilumab, potentially increasing the risk of CTCL in these patients.
So the data that we have, what it has shown is that people who go on dupilumab, who have atopic derm and go on dupilumab, are more likely to later be diagnosed with CTCL than people with atopic derm who do not go on dupilumab. On initial, as I say that, you would think, oh, it sounds like the dupilumab is increasing the risk. Well, no. It is that the people who go on dupilumab have worse atopic derm. They have moderate to severe. People who do not go on dupilumab have mild atopic derm. We have known for a long time that a small number of people who look like they have atopic derm actually have CTCL. Those people will have moderate to severe atopic derm. So when you start somebody on Dupixent, there is a 1 in 600 chance that when the dermatitis gets better, the non-specific reaction against the malignant lymphocytes, when we get that non-specific reaction to go away, now we can see the CTCL. We can see the malignant lymphocytes on biopsy. So it's not that the Dupixent increased the chances of getting CTCL. They already had CTCL before you started the Dupixent. You just couldn't tell.
Right.
The Dupixent allowed you to tell, oh, this is CTCL.
Right.
And at that point, you would be like, "Oh, okay. Now I know I was wrong when I started you for the Dupixent with the atopic derm. We're going to stop that and treat you for the CTCL now." And you have done absolutely zero harm. You've probably helped the patient by helping get to the right diagnosis more quickly.
Okay, so these people sort of filtered into the trials.
Yes.
and got reported, of course, the way you're supposed to do it. So let me ask you this question. If you have a patient with a known history of CTCL, and they are presenting years later, let's say they're in a remittive state, let's say, and they present with atopic dermatitis, are you kind of stuck here? Like, are you not giving IL-13?
Wow. So that's a fantastic question. So as I'm thinking this through, and so what I'm picturing, somebody who 20 years ago was diagnosed with CTCL, or 5 years ago,
right.
Maybe they got ultraviolet therapy, maybe they got whatever, they haven't had CTCL for years, now they've got a rash,
right?
I biopsy it, I say to the pathologist, they've got a history of CTCL, and the pathologist says, I don't see any CTCL, looks just like AD.
Yep, exactly.
I would have no hesitancy starting them on Dupi,
okay,
but I would certainly see them back probably every 3 months,
okay,
and have a low threshold to repeat the biopsy if their rash doesn't clear or if it starts to look different.
Okay, great. And then finally, that's great, very useful. Then lastly, you mentioned dupilumab in context of arthritis, maybe new onset, new symptomatology. So tell us about that.
So it is fascinating what we've learned about this. So I still remember the first person that I had who got arthralgias on Dupixent. It had not been reported in the literature yet. So I said, oh, you probably just caught a virus, you're feeling achy. That guy had to use a walker, he couldn't get out of bed. It took 6 months for it to resolve once we stopped the Dupi. And so then it was a mystery for a while, but then other reports started to show up in the literature, and we now understand this completely. So what's happening, IL-4 is expressed in all of our joints. So you've got IL-4 in your joints, I've got IL-4 in my joints, everybody's got IL-4 in their joints, because IL-4 is anti-inflammatory against Th1 and Th17 inflammation. So we have IL-4 to protect our joints from inflammation. If you are predisposed to getting psoriatic arthritis in particular, and we come in and block your IL-4, now you've taken away that protective effect, and you get what is really, in essence, new onset psoriatic arthritis.
Okay, and so this sounds a lot like the story of why we see the red face thing, because as I've seen you say before, that is an expression of seborrheic dermatitis because of the loss of those protective inflammatory factors.
Exactly right. It's a slightly different, so in your face what happens, if you are somebody who is reactive against malassezia and you've got excess IL-4, the IL-4 is actually protecting you from the seb derm because it is inhibiting the production of IL-22. IL-22 is the hallmark cytokine of seb derm. When we block the IL-4, now your body that has been wanting to produce IL-22 in response to the malassezia but couldn't because of the IL-4, now it's able to start producing the IL-22, so you get this new onset seborrheic dermatitis. It looks a little different from regular seb derm because it's kind of an overlap, seb derm, atopic derm. But yes, the red face, the arthralgias, and we know that about 1% of people who go on Dupi will get new onset psoriasis. Again, it's the same thing. Those are people who are predisposed to psoriasis. again, you can think of it as the excess IL-4 from their atopic derm has been protecting them from the psoriasis. And so then whenever we take away that protection, the psoriasis that they would have gotten anyways now can show up for the first time.
Okay, so this is very practical. We see a lot of crossover with these conditions.
Yes.
So this puts us in a position to give us a little bit more ammo for making clinical judgments. Okay, fantastic.
Yes.
So we had a lot of questions from the lecture. So let's go through some of that and see if we can help out some of our attendees here.
I love this. The questions that the STPA members have are such good questions.
Right, good. All right, so we're glad you feel that way. So let's start, they vote these up, so we're going to start with the most voted up questions, okay? At what point would you stop Dupi therapy in a controlled pediatric patient? For example, parents want to stop the injections for whatever reason.
Yep, so, and that is a very reasonable thing because number one, we know that as kids age, their barrier function gets better, so some kids kind of outgrow their atopic derm. And we also know that by changing their immune progression, we may have sort of stopped the atopic march and stopped their AD. So it's actually a much more reasonable question in kids than it is in adults. So in kids, the way that I think about it, if they are 100% clear for 1 year, so literally no flares, no nothing for a year, what I then do is say, okay, let's space it out to every 6 weeks. Okay. And if we can do that for 6 months, let's then space it out to every 8 weeks. And if we can do that for 6 months, then let's try stopping it.
Yeah, so you're ramping down, see if you can get them off.
So that if it starts to come back, I'm not like starting from scratch.
Okay.
I can get back the efficacy very quickly.
Okay, so in adults, let me flip that. So in adults who are doing well, let's say extended amount of time, let's say a year, and they're doing well, would you feel the same way? Do you feel like you can episodically stop it, see how you do?
Yes.
Right, okay.
Absolutely. If the patient wants, and so my advice to an adult is always this. It is safer to stay on the Dupixent because if we stop it and you flare, there is a real chance that you're going to get a MRSA infection.
Right.
We know the Dupi protects you from that. But if you really want to try stopping it, in adults, it's exactly the same thing. Let's try going to every 4 weeks. Now, in adults, I usually do, to be honest, I still usually do 6 months. Let's go to every 4 weeks for 6 months. Let's go to every 6 weeks for 6 months. Let's go to every 8 weeks for 6 months.
Great.
And then if you're still fine, then let's go ahead and stop it.
Okay, awesome. Very practical now. Okay, I'm sure that answered the question. So, and by the way, I'm atopic. And I've done that very thing to get off the medication. Yeah. I go on very long stretches without having to use medicine, so I can attest to it.
And let me tell you what I think is happening. I think that once we restore the barrier, and so the reason I want people to be clear for a year first is I want their barrier to be as perfectly normal as it can be. I think that then we can stop any of these drugs until something happens, and that something could be weather change, sudden weather change, air pollution gets bad, you go to a hotel and the sheets are not well rinsed, so there's residual laundry detergent. Until something happens that harms the barrier again, I think that remission can go for months or years.
So maintenance, like barrier repairing type moisturizers, things with natural moisturizing factors.
Taking a ceramide orally, those kinds of things, I think can extend it.
Okay, awesome. So we got a question from a viewer off camera here, and she mentioned the confusing picture sometimes of a classic scaly dermatosis and eczema. And is it psoriasis? Is it atopic dermatitis? You do biopsies. One looks maybe.
Well, let me read you the biopsy report.
Okay.
Psoriasiform epidermal hyperplasia with mild to moderate spongiosis and scattered eosinophils in a superficial perivascular lymphocytic infiltrate.
And a partridge in a pear tree.
Yes,
right,
exactly.
So that's it, verbatim. So you don't know which way you're going. You start in IL-13, they're not really getting better. So, is there something that you can do to predict which direction you want to go?
So, at this moment in time, no.
Okay.
In the not distant future, we will have a skin tape thing that you'll be able to send it in, and they will measure how much IL-13, how much IL-17, how much IL-23, how much IL-31, and they'll be able to tell us not just Is it more likely psoriasis or eczema? They'll also be able to tell us which drug would be best for this person.
Right, and so it seems like this technology, it's available. We have the gene mapping and things. It's similar to the pigment and lesion assay test. So how realistic, like how soon do you think that technology is?
Well, it is commercially available in psoriasis already, where we don't need it, right? But if I put you on an IL-23, there's a 90% chance you're going to do great.
Sure.
Like, I don't really need. And
right.
I would bet in the next 2 years, I'd be surprised if we don't have something. Now, that's going down the line. In the meantime, you've got a choice in that situation. So you can either think diagnostically, and if I'm thinking diagnostically, I'm going to base it on itch. So if they are like really itchy, I'm going to treat them with an IL-13 inhibitor, right? And I lump Dupi in as an IL-13 inhibitor,
awesome.
right?
Yeah.
If they're like not that itchy, I'm going to treat them with an IL-17.
Okay.
And if 3 months, if they didn't get better, I'm going to flip and use the other one.
Right. So symptomatology is dictating, and then maybe a little bit of therapeutic.
Yes, I call it a diagnostic therapeutic trial.
Sure, there you go.
Now, the other way that I can think about it is, I just want this person to get better. In that case, I'm going to call it atopic derm and give them a JAK, because a JAK works for both AD and psoriasis.
Okay, great. Okay. And here's a question that is kind of near and dear to me because I recommend it often and do it myself, is what are your thoughts on bleach baths?
All right, so first I'm going to say little kids, I think the jury is out. So I think they do really help some little kids. I think other little kids, they don't help and maybe make it worse. So in little kids, I think it's the right thing to do, but to tell the family, if this doesn't seem like it's helping, you don't need to keep doing it.
Okay.
In adults, honestly, I think it's kind of a moot question, because it's just hard for me to imagine that, like, if an adult needs to do a bleach bath, just put them on Dupi, or just put them on Lebri, or put them on a JAK.
Okay.
Like, if somebody told me, Matt, you can live an extra 3 years if for the rest of your life you do a bleach bath twice a week, I would be like, I'm dying 3 years early.
Yeah.
Like, I am not going to do, because it's hard. Now, if you have an adult who wants to do it, if they came in and say, hey, I read about these bleach baths, fine, go ahead.
Okay.
Like, try it.
Yeah.
But we don't really have literature to support it in adults.
Okay.
And we now know adult atopic derm is a totally different disease in terms of, why you have it compared to pediatric AD. So just because bleach baths work in pediatric AD doesn't suggest that they're going to work in adult AD.
Yeah, and you said in your lecture that if you have a spongiotic dermatitis biopsy proven in an adult, that's atopic unless it's contact dermatitis.
Yes.
So talk about that difference you're talking between adults and pediatric atopic derm.
So we now know that pediatric atopic derm is a genetic disease. Adult atopic derm is an acquired disease where it is the low-grade continuous exposure to things like air pollution, soap, laundry detergent in your clothing that is slowly damaging your skin. And the way that you really want to think about an adult with sponge derm is, instead of saying, is it flexural, do they have atopic comorbidities, because the data has shown neither of those two things matter. Most people with adult atopic derm, it's not flexural, they don't have atopic comorbidities. You should think, could this be contact derm? And the first thing you do is treat it as contact derm, and then if they don't get better, then you say, okay, they didn't get better as contact derm, I've ruled that out, now I'm going to treat it as atopic derm.
Great. So I think that's really practical too, because what you'll hear from patients, in the small knowledge they may have of atopic dermatitis, is I've never had it before. And so they try to talk their way out of the diagnosis. And so these are the factors that I try to explain to them in terms of
low-grade exposure to soap, hard water, air pollution, all of that stuff.
That's all right. Great. Fantastic. So here's a question on JAKi labs. What labs do you do for JAKi? How often do you do them? Where's the red shirt?
So the red shirt I always wear Maui Derm.
Yeah.
So that's why I don't have it at the SDPA.
Yeah.
For JAK inhibitors, at baseline, you're going to do TB, Hep B, Hep C, CBC, CMP, and lipids. You're going to repeat those at 3 months. And if they're fine at 3 months, you're going to do CBC, CMP, and lipids once a year going forward.
Okay, great. Perfect. And there's some on-label recommendations for that, but it's, beyond the initial screenings.
Yes.
It's kind of, there's nothing really written in stone.
Right.
Yeah.
It's as dictated by routine clinical practice.
Right.
What people are all doing in real life is once a year.
Right, exactly. Okay, here's a very specific question about allergens. Polyester fabric and atopic dermatitis. Are our athletic kids wearing the synthetic clothing and the stretch clothing and stuff, right? More likely to get AD as they age because of the chronic exposure?
So, my bet would be that if a kid is, so I'm thinking about a teenager, I would say yes, but I would expect so if they have existing AD, I think immediately that stuff is likely to make them get itchier and get worse. I would say that the damage caused by the residual TDI and xylene in that clothing probably has a 10 to 20 year lag. So yes, I think they are more likely, I would bet they're going to be more likely to have AD in the future, but 10 to 20 years in the future, not 6 months, 2 years in the future.
Yeah, it might be hard to make that association with that big of a gap.
Yes, it's good. But like we do have data that, for example, infants who there are polyester sheets in their crib have a higher likelihood of developing atopic dermatitis.
Great.
So that data, we do have that direct evidence that fabrics increase the risk of atopic derm.
Okay, fantastic. And another question, your opinion on wool fabrics. I have my own on this, being atopic, but...
So I think wool is a physical, right? If you look at wool microscopically, it's got the little barbs on it, and I think it is the physical poking.
Yes, that's the way I feel about wool. It's just you're just putting on something that's just itchy by nature.
Yes.
Right, okay. And here's an interesting question. They asked if you've ever seen new onset atopic dermatitis. I'm assuming this might be biopsy-proven spongiatic. Middle-aged, 30 to 50s-year-old, and more prevalent on the hands and the feet post-COVID vaccine.
Absolutely. So COVID vaccine, you can think of as a reasonably non-specific, it has specific immune stimulation to the COVID stuff, but it causes in many people some non-specific inflammation, and if they were atopic dermatitis predisposed, I've absolutely seen people develop what meets criteria for atopic derm following a COVID vaccine.
Okay, great, fantastic. So that's something I have not personally observed. Now I got to look out for it. So, all right. They mentioned here, this is not something I've heard of. Is there a risk of future infertility with an oral JAKi?
Yes.
This patient, Claudia refers to a small animal-based study, a mice-rat study.
Yes.
Yeah.
So it was a rat study, and the rats, and it was specifically with abrocitinib. It was a very high dose. The rats had impaired fertility while they were on the abrocitinib. As soon as they stopped the abrocitinib, their fertility went back to normal. That does, though, bring up a different question that I like to talk about that a lot of people don't know. Having active atopic derm makes you less able to conceive. Okay. And so the reason that's important, I've had patients who, and this was several years ago, for years, I was like, they were trying to get pregnant. And so I wasn't treating them, didn't want to give them Dupie. A couple of years went by them trying to get pregnant, not being able. Finally, we're like, you know what, I can't let you keep suffering. Let's just go on the Dupie. As soon as their atopic derm better, they got pregnant. And then we stopped the Dupie. They were able, I
think there's things in the literature about these kinds of things.
There is. And so I think that's important just to know that if you've got somebody trying to conceive, active atopic derm makes it harder to do so.
Okay. Here's a very specific one. These things come up. Do you have a body soap, body wash that you specifically recommend in atopic derm?
So my recommendation is hot showers with no soap. So I specifically like Dove unscented sensitive skin bar, but I tell them only use that in your armpits, your groin, your face. Now, if you need to soap up, fine, right?
Yeah.
Because you've got to remember that the way that soaps work is to remove, right, the dirt and the gross stuff is on the surface oil layer.
Right.
And so the soap is to, rinse, allow the soap to be soluble, or the oil to be solubilized by water. Hot water already does that. Hot water. So think about butter on a plate. If you use hot water, you don't need any soap. The butter just rinses away. If you use cold water, then you need the soap to dissolve the butter. Hot water gets people clean enough without exposing their body to no matter what soap you use. If it is a soap, it has some damaging effects on your keratinocytes.
Okay, great. Last quick question. Any concerns about giving JAK inhibitor to older population?
No.
Okay, very good.
Only a cover my ass concern.
Yeah.
So whatever their risk is at baseline for cardiovascular or thrombotic events, their risk is going to continue to be the same on the JAK inhibitor. It is purely okay, so if they do have a heart attack, is somebody going to come back and say, well, you put them on that JAK inhibitor?
Okay, right.
I'm going to point to all the literature that says, well, that didn't have anything to do with it.
Yeah.
But if I want to avoid having to even think about it,
right.
Okay.
That's awesome. Yeah, the data is my shield, right?
Yes.
Yeah. Okay, so are you a movie guy?
Yes.
Yeah. And are any superhero movies? I mean, do you watch superhero movies?
Yes, and I...
Which superhero do you identify most with?
Mostly Tony Stark.
Okay.
But that's largely because I like to identify with Elon Musk, and I think of Elon Musk as the Tony.
He's kind of an
He's a
iron,
real world
right.
Tony Stark.
Yeah,
I
get that.
He's
I get
building
that.
the world's largest supercomputer. So
Yeah,
I think
okay.
he's building that to have his own.
All right.
The thing that Tony has in the AI that he has in
the arc
movie.
reactor.
Yes.
Yeah. Oh, you mean the Jarvis? The
Yes, Jarvis.
thing.
I think Elon Musk is trying to build his own Jarvis
Okay,
now.
we definitely are showing our nerd sides right now. But it's basically Tony Stark, Elon Musk, and Matt Zirwas.
Yes.
Okay,
Yeah.
I dig that.
Yeah.
Hey, man, it's always good to sit down with you. Thanks for taking so much time supporting the SCPA. You've got a couple more lectures through the course, so we're looking forward to all those. You got one on contact derm. Might try to catch you on that too. But thank you so much for the time, your support, and just dropping the knowledge, man.
Thanks, man. I love being here.
Good to see you as always, brother. All right. Hey, this is Rob Casqueo at Dermcast Live. Thanks for watching.